Good evening, everybody, or good afternoon for our US attendees. My name's Simon Ramshaw. I'm Managing Director of Aconia Lasers Limited. We're the Europe, Middle East and African subsidiary of US-based Aconia Corporation. I appreciate a lot of you have been on before, so you've heard a lot of what I'm about to say, but there are a few new people on the call, so I would like to just go through it again and try not to keep you too much. When we launched in the UK market, especially, it was when Dr. Robert Sullivan, who had 6-7 years experience using our non-thermal lasers in his clinic in County Cork, when he absolutely loved them and decided or agreed to come on board as the clinical educator, responsible for everything to do with the training for our lasers, and his, long understanding of being Dean of Education at a specific organization, and also with the amount of research and science-based studies that he's done, he's been, an absolutely fantastic advocate of us, of our company, and has provided us with immense support over the years, which we very much appreciate. But the biggest thing we found was that there was a lot of gray areas when it came to low-level laser and photobiomodulation. So after hearing a lot of people say we had a laser and finding out that it was either LED or it was infrared with a completely different delivery mechanism, we decided when we start our educational webinars that we'll actually go back to basics. So Rob, being the researcher and scientist that he is, has done a lot of outside research away from Aconia on non-thermal low-level laser and other modalities which fit into the low-level laser category. And this has been the basis of this very successful series of the scientific underpinning of low-level laser, which is part 3 tonight. Anybody who wasn't on for part 1 or part 2, please email Julie in the office and she'll make sure that you've got a link. I think a lot of you were on those, so this is the finale, so to speak. A lot of you know, if you look down the right-hand side of the go-to webinars, you have a questions section. So please, as we're going along, Julie and I will keep checking that while Rob's doing his presentation. And when we get to the end of the call, we'll fire the questions at Rob. So please don't be shy. Ask as many questions as what you can. It's not just good for yourself, but also for everybody else that's on the call. And also for us, because there may be something that we hadn't thought about that either myself or Dr. Rob can go away and research. So welcome again, and I would like to introduce you once again to Dr. Rob Sullivan, who is a reconstructive orthopedic podiatrist based across in County Cork in Ireland. Rob, we've had the pleasure to know him for about 8 years. And he's been responsible for a lot of third-party research, as well as research on behalf of Aconia, looking at non-thermal lasers for things like fungal infections, diabetic peripheral neuropathy, pre-diabetes and obesity management. So he's in a very, very strong position to be able to lecture on this subject. So without further ado, Rob, over to you, and I look forward to listening also.
Very good. I hope everyone can see my screen. So just checking in with Julie. You can see my screen?
Yep, perfect.
Right, very good. So slight change of title, slight change of presentation. But as Simon said, any questions that you wish to ask, please feel free to ask the questions. This is, I suppose, the final lecture in a series of 3. So what I want to do briefly is just jog memories on what we spoke about, mine especially because it's been a long day. So the first thing we looked about was the whole thing behind the principles of photobiomodulation. And photobiomodulation is a form of medical intervention that uses non-ionizing radiation. And it can be delivered as light in many forms. The best delivery mechanism from a scientific point of view for photobiomodulation is non-thermal low-level laser or low-level lasers. The controversy really in my mind about that is if you're using a true non-thermal low-level laser, you are taking light from the electromagnetic spectrum. You are shining that light at the body to create an energy wave that passes through. That wave delivers photonic energy. So my argument is this really non-thermal low-level laser? Is it really photobiomodulation? Then if you remember, we had a look at what we think we know. And what we think we know really comes down to the basics of when we all started in college and university. One of the first things we looked at was a cell. And I suppose from my point of view, I got very confused about all of these things like the Golgi apparatus and the mitochondria and all of the other bits and pieces that were in it. And, you know, I thought, oh, I'm never going to get this. But what we thought we knew from all of that was that the mitochondria was the powerhouse or the driving force of energetic transfer within the body. But what we've found out really only in the last 5-6 years is that that's not true. It's only partly true. It's partly this energetic driving force of the body, which basically empowers us to heal, empowers some of us to grow hair, and basically empowers our body to rest, restore, and rejuvenate. So what we thought we knew is very different to what we know after this series. Another thing we thought we knew was that aging was just something that happened and we couldn't do too much about it. We were going to lose viable mitochondrial processes. We were going to lose mitochondrial RNA. We were going to lose DNA. We were going to lose the specificity that they create. And in so doing, we were going to age and we were going to die. You're still going to age and die even after listening to me and watching this series, but you're going to understand that these devices, not just ours, but low-level laser devices that are true non-thermal devices, they actually produce, as we saw from the research, that mitochondrial process in order to produce the DNA, the RNA synthesis that we need. So what we thought we knew changes. So then we looked at why non-thermal low-level laser, and the reason for that basically is because it increases the viable number of mitochondrial DNA, RNA processes. It increases cellular communication, so intercellular, extracellular communication. It signals and triggers other mechanisms within the body. So this very, very small little, I suppose, organelle within a cell, it serves a very specific purpose, because if you go back in time, it started off as a piece of bacteria in the primal ooze that got into our cells and became something different. And then we looked at the whole concept that beauty is no longer skin deep. You know, I get up in the morning, I do a little bit of shaving, I put some moisturizer on my face, I look in the mirror and I think how good I look, but I don't think, how do I look inside? That beauty on the outside is only skin deep. If we can change processes within us, like mitochondrial DNA, RNA processes, if we can change specificity or assist that, then we can empower the body to change. So all of these beautiful things inside us, these cells, these organelles, the components that make up me, they can become beautiful because I'm putting the moisturizer on them that I'm now putting on the outside through the intervention of light. And then we looked at the positive effects of specific laser beams or nanometers of light. We looked at 405, we looked at 532, we looked at 635. So basically violet, green, and red. So that's your whistle-stop tour. So briefly, we're going to recap over a few things again, but we're going to pull it together because this is the last one. What I really want to look at today is the concept of prehabilitation within a multidisciplinary approach. So not just prehab of muscles, but also prehab of the tendons, the bones, the tissues, even the cells themselves, the prehabilitation of us. We'll do a little look around wound management. There are 2 nasty slides, so hopefully you've had your dinner or you have a suitable receptacle nearby. And then we're going to basically have a few conclusions and look at any questions that you have. So please, if you do have questions, write them down on the screen, as Simon said. There's no such thing as a silly question. There are only silly answers. I will try not to give you them, but ask the question you want, because there's somebody out there who's asking the same question and they don't want to type it up. So what we know basically that non-thermal low-level laser as a discipline within therapy has been used really quite a lot within the sports area for a long time, really because of its effectiveness in recovery. And we've never really completely understood until now that recovery mechanism. So if we look at some of the studies from a little while back, this study basically is from 2013, and it's a study in laser surgery, phototherapy, and photobioactivation. And it basically said that the effective rate of non-thermal low-level lasers above other modalities used was 66% in a 41-patient study. That might seem quite low, but when you consider that the majority of medicines that I could prescribe, you could prescribe or give, have that or less. But when you look at other papers suggest far, far higher rates. And when we look at older papers, newer papers, we're going to see a varying difference of rates. And if you are looking at papers in order to inform you around this subject, then look at things that are randomized controlled studies. Don't look at anything else. Another thing that's good to look at is when you look at the evidence in terms of clinical evidence. So clinical papers of people who've used this kind of stuff. Have a look at that. So non-thermal low-level laser, in reality, in today's market, according to a recent paper, which I haven't got here because I didn't have time to reference it in, by Gupta last year, basically suggested that in a sports recovery setting, in a rehabilitation setting, that non-thermal low-level lasers could be as high as 89% effective. That was his suggestion. He was really looking at things like jumper's knee, tennis elbows, Achilles tendonitis, gastrial problems, groin strains, lower back, and that kind of thing. So the stuff that is, for a lot of us, the bread and butter of what we do. So the important thing to remember with non-thermal low-level lasers is that they deliver photons into the body in a laser beam that basically affects the tissues at a cellular level. And the laser basically, as it enters into the tissue, it basically adjusts cellular membrane permeability. And as a result of that, it ultimately hits and gets into the mitochondria. And in that state, in that place, that's where it has the physiological benefits which allow us to recover from injury. And that happens by creating more oxygen within the body, creating a better blood supply, creating the ability of the body to sort of free itself from phagocytosis through expression and other ways. So what do we see when we stick these lasers on the body? So I'm talking specifically now about 405, 532, 635. So those three frequencies, they're going to have a similar effect. Some are slightly more effective on other things, and that's where you can ask questions later. But all of these lasers basically create rapid cell growth. And what that basically means is it speeds up the production of our cells. And as it speeds up that production, it allows us to recover more quickly because it stimulates the development of fibroblasts and other damaged tissues. And by doing that, it allows our body to repair. So if you're listening, what we're actually saying here is that the laser beam is a delivery system for photonic energy. The photonic energy is empowering our body to change. So if I put moisturizer on my face, I'm empowering my skin to respond to that, to change. If I put the laser beam on the body and bring that photonic energy in, I'm moisturizing my cells. I'm making them more youthful. They can behave in a better way. They can produce things that they may have forgotten. So it's not just fibroblasts, it's stem cells. It's pretty much everything that we need. So as that happens, we see higher metabolic activity. So we'll see increased output of specific enzymes, like I've mentioned. Again, they're, like we've already said, greater oxygen within the blood cells and a stronger immune response. That's very important, because if you have an injury, something very strange happens within the person when they have an injury. Now, when we get to the case study, we're going to talk about that, and I'll explain a strong immune response in relation to that, because that strong immune response is beneficial to muscle recovery, it's beneficial to tendinatic recovery, skeletal recovery. It's also beneficial to general health and recovery from disease, or dis-ease, as you might say. Another thing that's important with these lasers, and for me, from a surgical point of view, it's actually absolutely brilliant, because years ago, I can remember doing surgeries for things like Morton's neuromas. And in those days, we used to make the incision in the sole of the foot, and the amount of scar tissue we would have would be absolutely horrendous. And sometimes you'd have to revise the surgery for that scar tissue. Now, if I'm doing a Morton's neuroma, I go into digitally, so I go in between the toes. But I use the laser pretty much before and immediately after. And the reason I do that is because it lowers the ability of the body to create fibroblastic formation within the tissue. And when it does that fibrous tissue formation, you basically get really, really keloidal type scars and things that are quite hard to walk on. So because the laser empowers the body, it's allowing the body to heal in a natural way. So even though I've created a wound, my body is able to heal itself by better intent, by allowing unionization of those cells. So what we get is we get a better wound closure, and we get better cellular colonization. So we don't see that scar tissue. So if we put that into plastic surgery, if we put it into aesthetic dermatology, it has a very, very viable place, especially when we start looking at cosmetic procedures on the face and parts of the body that are highly visible. The other thing that these lasers do, which I think is amazing, you can get a far faster anti-inflammatory response from a laser than you can from anything that I give you as a tablet or anything I stick into you with a needle. And basically, by doing that, by reducing swelling, you basically allow a bruise to do what it's supposed to do. You reduce the inflammation in the tissues and the joints, and as a result, you improve mobility. So all of this taken into account, and the increased vascularity that comes along with that, so the increase in the microcirculation, also helps with stimulation of lymphatic flow and helps to basically pick up all of the toxins and stuff that are in the tissue as a result of that. And whenever we have a tissue that's damaged, there is always going to be, there is no tissue damage without nerve damage. There is no nerve damage without tissue damage to an extent. And what also happens with this is this will speed up the process of connection or reconnection within nerve systems. So an example there, I had a patient recently who had a spinal fusion, which is something that I don't like to see because it will cause quite a bit of nerve damage. And the fusion that they had was L4, L5. So as a result of that, there was a little bit of, I suppose, paresthesia in the butt and going down the legs. And if I used the laser on it, I could get a little bit of relief from the patient. But it wasn't joining up. There was something missing. There was that nerve link up missing. So the nerve here would feel better. The nerve down here would feel better, but in between still didn't feel right. So what I did with this particular patient was, do you remember the old-fashioned TENS machines? It used to be a little black box. I had one of these, and I got the old TENS machine. The pads weren't the best, so we cleaned them up and we glued them up and we stuck them on. And I put them on either side of the incision. And I switched it on, and when the patient felt a tingling sensation, I lasered above, I lasered below, and I said to the patient, tell me when the pain in the middle, or that numbness in the middle, goes away. And the person said it went away. So we increased the pulse, and the pain came back, so we lasered some more and the pain went. And we repeated this over a week. We did 3 sessions, which is unusual for me because I'm a once a week guy. And at the end of the week, she actually felt no numb sensation in that. My theory on that is the nerve was damaged, so you had the bit of the nerve here looking for the bit of the nerve there, and they couldn't find each other. So by creating an artificial connection between those nerves, by using that electrostimulation, we were empowering the body. We weren't doing it. The laser wasn't doing it. The body was empowered by the laser to make that repair or connection between the damage. So last week, we had some questions that were sent in, and some of the questions were about irradiation parameters, things like frequencies and stuff like that. I'm not going to spend too much time on this. I'm going to run through it a little bit quick. So what we need to think about is traditionally lasers are talked about joules per square centimeter and things like that. For a non-thermal laser, that's a completely irrelevant concept, and it really doesn't apply. And the reason it doesn't apply is if you read the text there, it says that light is packets of electromagnetic energy that also have a wave-like property. So what that basically means is a laser beam has a wavelength, okay? Down that wavelength, we're passing these little packets of light, okay? When I create energy in a wave and I point it at something, that energy is going to continue to express itself in the physical universe because that energy cannot be destroyed. So it will pass through everything that it comes in contact with until ultimately it's absorbed by the physical universe. What stays in the body are the little packets of electromagnetic energy because they have been absorbed by the mitochondria. So when we talk about joules per square centimeter depth of penetration, it suddenly becomes grossly irrelevant because we're getting the energy into the mitochondria. And if this mitochondria has enough, the energy will go on to the next one, and the next one, and the next one, and the next one. So when we talk about wavelengths in non-thermal laser, typically in the research in days gone by, they talked about 600 to 1,000. Now we're talking about 400 to 800, and we don't go too much above that. So that's the wavelength. Then when we talk about irradiance, then we're talking about, this is where the whole thing of, I suppose, per square centimeter, or watts per square centimeter and all of that come in. And this is really a little bit irrelevant because when we talk about power density, technically what we're saying isn't correct because power doesn't have a density. Substance has a density, power doesn't have substance, it has energy. So when we look at that and we look at the irradiance of something per square centimeter, we're not really getting there when we're talking about non-thermal low-level lasers. When we talk about pulses and structures, what we're basically talking about there is if a beam is pulsed, then the power which is put through the beam is averaged across the time of that cycle. So I'm not going to do too much of this because it really does get extremely technical. It's there if you guys want to read through it when the presentation goes out. What I'm trying to get to here is we need to start looking, instead of depth of penetration and joules per square centimeter, we need to start looking at medicine and dose. So with my clients, if I'm going to give them an anesthetic, I need to know how much of a medicine I can give them, which their body can absorb, and what dose of that medicine do I need in order to have the effect that I want. So what I want you to start doing is, if you think as irradiation parameters as medicine, and then if you think of time and energy in terms of dose, then suddenly the lasers become a little bit more simple. So if you look at what we have there, we're talking about energy, joules per square centimeter. Have a read of it, it's interesting when you get it. forget about it. When you look at the density, you're talking about joules per square centimeter. As I said, density in terms of energy is irrelevant because energy is not thick. Energy is very fluid. Energy is very energetic, for want of a better word. So the important thing for us is irradiation parameters. So irradiation is time. So if we break it down and make it as simple as we possibly can, the safest way to record and I suppose prescribe non-thermal low-level laser is basically to define the irradiation parameter. So the irradiation parameter is the medicine. And what that basically means is, what am I going to use? If I'm using one of these devices, I'm using a 405 and I'm using a 635 nanometer laser beam. And I am using that to deliver a prescribed amount of energy to the body for a particular time. So if you think of the energy that I'm delivering, we'll give you a frequency 1015, 1015, 1015, which is a nice frequency for the brain. Then that basically is going to be my medicine. My dose is the amount of time I subject the body to that medicine or that irradiation. And it's really as simple as that. And because these non-thermal low-level lasers are so subtle, we don't really need to worry about, oh God, what frequency am I going to use? And we go and we pull out Varuk's book and we have a look at it, and we look at it and think, oh God, there's so many of these things in here. If you have that book, it's a wonderful book for bedtime reading. It's great for insomnia, and it's got a lot of amazing good stuff in it. But the reality of it is, most of us that use these, and you've heard the lectures that the American guys give as well, we use about 5 of those. And the reason we do that is the most important thing for us is to get the energy into the body. And if we get the energy into the body, we've given it the food, we've given it the moisturizer, we've empowered it to make that change. So we're giving the body the energy to make that change. So when the presentation goes out to you, if you just click on the links below, it will take you to the full article. This comes from an article which is very important. It's called The Nuts and Bolts of Low-Level Laser. There's the article. If you haven't read it, just click on that when you get it. It'll take you straight to the page. It's free to access. Click on that, and you'll see that the guys that wrote that are saying very much what I'm saying to you in terms of don't worry too much about how much, for how long, just get the energy in. So now that I've bored you completely to tears, we are going to have a look at the concept of prehabilitation. So we all know what rehabilitation is. Rehabilitation means I have my arm, and I can't move it. You know, oh, it's really bad. So you go in, you see a wonderful physiotherapist, an excellent chiropractor, a loving tissue masseur or whatever, or you see an idiot like me and we say, we'll fix that. We stick the laser on it, we fix it. Why do we have to keep fixing things? Why in our lives do we always have to be reactive? What if we approach our lives from a different way? What about if we approach our therapy from a different way and we approach it as being proactive? Proactive is what prehab is. I injured my arm, for example. And I injured my arm because I'm an idiot and I do the same thing over and over again. And instead of adjusting my backswing or my tennis racket playing or whatever it is that I'm doing, I continue to put myself through the same level of pain. So I'm going to present with the same injury. And I'm sure you, as well as me, we get tired and bored with the same people coming in with the same thing all the time, not learning anything from it. Prehab is what we can do with them to prevent those injuries. So when we take somebody into prehab, what we're looking to do is we're improving muscular response. And as we do that, we reduce the stress pretty much and the lactic buildups. And when we do that, what we're actually doing is we're pre-warming and I suppose preheating muscles and joints. And when we do that, that will naturally improve performance and it will assist response, because injury is caused by lack of response or lack of response, because if I twist my ankle, it's because my subtalar joint didn't respond quickly enough to the mobile adaptation that my foot made in order for me to go off in the other direction. But we can change that. So what we're talking about doing is we are looking at motivating and improving the physiology of anybody, not just an athlete. And by doing that, we are extending their productive life in the sport or the recreational activity that they want to do. So prehab is what takes place before an injury occurs, and it's really a preventative or a proactive measure rather than a reactive measure, where we can use the non-thermal low-level laser. And we can use it basically to stimulate lymphatic and blood circulation. We can increase the output of enzymes in the body and generate greater oxygen within the blood to feed the cells. We can produce that stronger immune response, as I mentioned earlier, and we'll take a little further in a minute. We can improve elasticity within the tissue. Any of you that have a laser, if you just switch it on for a minute and go like that, and then basically laser up and down your hand for 20 seconds and then go like that, you'll actually find a difference compared to the other hand because you've improved elasticity. What you have done is you have pre-warmed your tissue for action, and you've restored the balance within the axon potential, within the nerve, within the muscle response to that, and within the way the bone functions around that. So think of what we know about non-thermal low-level lasers and what they do to injury, and now equate that to the correct function. Now we have prehab. So I'm using a real case. I'm using a real guy's name. I'm using a real guy's photographs because he was delighted and he said, you can tell them my story. So Jer is a 24-year-old. He enjoys running. And unlike you guys in England and the rest of the world where you play this thing that you call football, in Ireland we really play football. We have the Gaelic variety, and it's good. And he was one of Ireland's, I suppose, or still is one of Ireland's big footballers, but he was also one of the up-and-coming rugby players. His nutrition, when I saw him, and it still is, his nutrition was very, very good. He was exercising 6 days a week, and he had one day as his recovery day. And he was what would be considered a professional athlete. In his words, his problem was that he had discomfort where his butt met his leg close to his scrotum, but at the back of his leg, at his right leg. So you know where we're going. We're going back to the piriformis and the ischial processes. So that's how he described it. So he described the pain as a tightness, the occasional numbness, and he said it wasn't nice, and he feels it more after he exercises. So straight away, you guys are sitting there now listening to me, and you're already putting together a picture, I hope. So when we examined him, his range of motions at the hip was good. There was some discomfort on upper flexion of the leg, not a lot, just a little. When we palpated or felt the area, there was some discomfort below the ischial tuberosity, as I'd mentioned. If we palpated along the posterior femoral cutaneous nerve, that was pretty much normal, but there was discomfort over the piriformis. So for those of you who don't know where all of those bits are, I'll stick a chart up here in a second. So in comparison to the other limb, the range of motions was normal, and the other limb, basically, there was no discomfort below or over the tuberosity itself. Hip flexion to both was pretty much normal as well. So basically, when you look at what he was talking about, his pain was here. His numbness was also there. There are your muscles that are involved. So your semimembranosus, your semitendinosus, your biceps femoris, your ischial tuberosity. And the rest of his pain basically was in the piriformis. So when you think of that, you can also think of the nerves that run through that area. So basically, when he first presented to us, it was basically he wanted to get some rehab, because at that stage he tried physiotherapy, he tried acupuncture, he'd had deep tissue massage, he'd seen a chiropractor, and he'd also gone down the allopathic route. So he'd seen the doctors, he'd seen the orthopedic guys, and basically nothing was working for him. So after everything eventually settled down with what we did to him, he was concerned that he would have to stop playing. He didn't want to. So I mentioned to him the whole thing of prehab. Maybe you don't have to stop. Maybe you have to adjust. So for him, we put the following routine in place. We basically got him to do warm-ups and exercises on day one with an exercise period. So what that basically meant is he'd come in, he'd do some exercises and some warm-ups, then he'd go off and he'd do his exercise. The second day, then he would do a rest day and he would only stretch. And on the third day, he would do warm-ups and exercises, and then he would have 2 exercise periods on that day. So we're basically increasing the whole time. On the 4th day, then it was a rest day with stretches only, and he repeated that pattern until normal function was restored. So the treatment that we did was basically like this. So the dermatome of the area or the region that was being treated, we treated that with the handheld. So that's the two that in our instance here in this clinic, it's a 2-headed laser. It's a red and a violet laser, as it says there. The settings that I put on this, so the settings is the medicine. The medicine that I put into this injection was basically 10, 15, 10, 15 hertz of light. So that's what I'm passing down the needle, which is the laser beam, into his body, okay, at the dermatome of those affected areas, so L4, L5, S1-ish. So then the laser was then moved to the area where the problem was felt by him for 5 minutes, and the settings that we used there, or the medicine that we used there, 96, 110, 532, 880 hertz. Again, that's the medicine. The 5 minutes, as you can see there, that's the dose. That's what he had. So that's your dermatome chart, just in case you're thinking, which dermatomes are we going to use for that area? So it's all pretty much explained to you there. So we did, in our instance, L4, L5, S1, S2. Basically, it went very well. So after we'd done this treatment with him, he did these stretches, as you can see. I should do those more. So the outcomes, after 6 applications, he no longer needed our support with this. The injury hasn't really come back, and he would pop in from time to time just for a natter, even though he's supposed to wear a mask, but they own the big local supermarkets. So occasionally, I threw them away, Simon. Occasionally he pops in with buns, with cream in and coffee. So he's still fine. What we basically do is he has a dynamic laser treatment if he's going to play a game and he hasn't sustained an injury. At the time we wrote this, in 6 months, he hasn't sustained an injury since. So basically, I asked him what did he think. So he said basically the injury that he had defied the team physio and it was hindering his career. He read an article about lasers, and basically he knew that we were doing it at the clinic here. He made an appointment. He's not looked back. And he said there, who knows, he may even play rugby again. He didn't make the squad, but he plays for the national county team as a proper footballer. So wound management. Wound management is very interesting, because if you remember, we talked at the beginning about the immune system, and we talked about improving that. Gerald wouldn't have improved without his immune response responding to his injury. In what we're going to discuss now, the case that we're going to discuss now is from one of my Nordic colleagues, Christian, who basically lent us this case. So in wound management, what basically happens is we need fibroblasts, we need keratinocytes, we need the proliferation of collagen synthesis, and we also need angiogenesis in order to improve and manage tissue, and in order to get wounds to close and cells to grow properly. And that's one of our biggest problems in chronic wounds. And we know from the research that I presented to you already that non-thermal low-level laser really has a vital role in that, because it gives us all of the things that we need. It gives us the stem cells, it gives us the fibroblast activity, it creates the collagen reprofiling, it allows the body to go into that genesis situation where it's improving things, especially when it comes into wound management. Again, I always like to show you the negative first. Paper in 2012 said that in diabetic patients and in wounds in diabetic patients, it was only 55% effective. Again, Gupta, the guy who did the recent paper, suggested it was a hell of a lot higher. There's the references. You can pick up on those later. So the patient basically had a bike injury, I'm told, 14 months ago, and he presented with a non-resolving neuroischemic ulcer. He is 45 years of age. He's active, but fits into the first stage of obesity. He had poor circulation. He had an arthritic hip. The medicines that he was taking at the time were blood pressure meds, aspirin. He took a statin. He took Vimovo. So Vimovo is an anti-inflammatory using a combination of diclofenac. And this is what it looked like before the treatment. So take a good look at that. And when you look at that, you're going to think that guy is older than 45, but look at the state of the tissue. The tissue it's solid, it's hard, it's rubbery, it's rough, it's scaly. Have a look at that. I was amazed at this too. Not amazed at what actually happened there, but I was amazed that in all, he had 2 treatments between those photographs. And I think that's pretty remarkable, because if you look at the quality of his skin, the quality of the tissue, the quality generally of that limb, and the improvement that is there just after 2 treatments. So when the patient returned for the second treatment, he was asked to notice, what did he notice? So considerably less pain, plus. Better sleep quality, excellent. Less smell from the wound. Well, that's good. You know, the second week, really the sensation around the wound, as you saw there in the appearance, it was a lot less red. The skin was more pliable. The skin there was lovely. The scaling had gone, and you had extensive remodeling of the tissues to the area. So I'm just going to throw at you some research that we did here with peripheral neuropathy, which is something that plagues rheumatoid patients, it plagues diabetic patients, it plagues renal patients. It's actually something that's very nasty for a lot of people. So it's lack of sensation to the digits of the hands, the feet. It can lead to sensational issues in the nose and the ears. And for men, it can lead to desensitization of the penis and impotence and things like that. So not nice. So peripheral neuropathy in diabetes is pretty much nerve damage, and it's the result of high blood sugar. Its cause is numbness and lack of sensation and pain, usually to the feet, the legs, and the hands. And it's actually the most common complication in diabetes. So about 60 to 70% of people with diabetes will develop neuropathy as a result of that at some stage in their life. And that puts them at a greater risk of nerve damage, and ultimately it puts them at a greater risk of amputation. So in the study that we did, we took 30 individuals in. For some reason, when we did the randomization equation, it played games with us, and it did 19-11, so that's what we did. So in this instance, we used a 635 nanometer standalone laser, so a big one. Size is irrelevant, by the way. It's just that it's a bigger device because it's on a stand, and we basically pull it down over the affected limb. And the placebo group basically had red LED. So the red LED would have maybe had a beneficial effect on the circulation of their skin, but not so much on the nerves. So they had 15 minutes of irradiation, so that's the dose. and it was 30 minutes in total because they have 2 feet. And they had 12 treatments over 6 weeks, so that's 2 treatments per week. And the method that we used, the patient was reclined on a therapy couch with their legs elevated. The laser was directed over the medial plantar nerve bundle, the lateral peroneal nerve, and the saphenous nerve area. And each patient receives, as we said, 12 treatments over 6 weeks, and we used a normal double-blinded randomized protocol. Your baseline variables there were duration of pain measured in months and years, whether the subject had insulin or not. Baseline medication for the study, if they needed it, was, and my staff here laugh at me with this, a gram of paracetamol. I basically get told, why can't you tell them just to take 2 paracetamol? Anyway. And also demographics was something that we looked at as well. So our measurements for this was the visual analog scale, and that was marked by the patient. So the way we did that was we had a line 100 mils long, please touch that in relation to where your pain is, then we could measure that. And that's how we recorded the visual analog scale. We also used the National Pain Scale Inventory, which is an accredited measuring system. We looked at adverse events and how many times they actually used the medicine. In terms of the paracetamol. So these are the mean VAS scores across the duration of the study. So the blue is the test group or the live group. The yellow orangey color is the placebo group that got the LED. So if you look at that, you can see very quickly the VAS levels came down over the course of 3 months, and they continue to go down. Whereas on the patients with the LED, even though it initially came down, it went back up, and it wasn't particularly a reliable intervention. So when we look at the National Pain Intervention Scale, this is what we basically see. So we see a very quick, marked decline in the pain scores. And we see that bottoming out and leveling off towards the end of the 3 months. Whereas with the LED patients, we see it consistently coming down. It would have been interesting to follow that up a little bit more to see if it continued to go down. We did follow it. I haven't reported it. It didn't continue to go down. So in order to qualify something that's going on in research, we always need to have something to see. So what we basically did with patients was we did punch biopsies, and the punch biopsies were basically taken in the calf of the leg and in the foot, and we were looking at the density of the end plate nerve system within the foot. So if you look at it here, sorry about that, if you look at it here, the one on your left is basically before. So if you look at that outer layer of skin, which kind of looks gray and or not so nice, that's what that guy's leg would have looked like before the laser intervention. Now, if you look at that slide again, and you look at those little black liney bits on the left-hand side, we're looking there for nerves. And those little black bits that you can see are nerve endings or the end plates. And if you look at the slide on the right, after the laser interventions were done, so that's 12, 6 weeks, you can see the proliferation of nerve density is higher. So just to sum up, when we use a laser, we're not doing anything. We are basically giving the body energy. We are giving the body energy, and by doing that, we are empowering the body to rejuvenate itself from disease. And I've written it as disease purposely. And that's all we're doing. That's all any of us can do. Like the first rule of medicine is do no harm. You do no harm by doing the least intervention you can. Light has been around for centuries. Lasers are a harnessing of that light. We are delivering that light to the body in order to empower the body to heal. Our skills, whatever our medical or clinical background, our skills allow us to deploy and manage where that event more readily takes place. So if I'm a chiropractor and I'm using it on an elbow and I employ it over there and I use movement, as we talked about in part 1 of this, movement tells basically the stem cells where to go and what to be. So we use our skills along with this technology to get a better result. So what can we use it on? What can't we use it on? So You can use it on fatigue, shortness of breath, chest tightness and pain as a result of stress. The most important thing with any intervention we do is know your patient, know the symptoms, do the tests, make sure it fits within your scope of practice. If you have a patient with chest pain coming in, don't just stick a laser on them. Have they got a heart issue? Do your due diligences, do your differential diagnosis. And when you do that, this tool is just a friend which allows you to pretty much treat what you need to treat. So what I hope we've done with this short program really is introduced you to the concept of light within medicine, but primarily introduced you to what you can do with a low-level laser within that. And basically the research that I have tried to present to you is to try and show you that our body uses this to empower itself. And laser is nothing more than a delivery system for that photonic energy, which is the medicine the body needs for a set time, which is the dose, in order for the body to utilize that energy for rejuvenation, regeneration, and restoration. That's all any of us are trying to do. That's what I try to do as a podiatrist, as a surgeon. That's what you guys try to do in your fields. So basically, it's a tool really that isn't like any other. It empowers our bodies to basically use the energies that we have to give it at a cellular level. No side effects, no pain, no downtime. Laser isn't LED. Laser isn't infrared. It's basically a non-thermal device. In my view, and this is purely my view, it's just a delivery system for electromagnetic energy. It's not about depth of penetration, really. It's not about joules. It's not about square centimeters of density. Because think about it, energy cannot densify. It's really about delivering a dose of medicine to the body that it can use. Welcome to the future of healthcare. Thank you for listening. And like it says, bring a little light to life with non-thermal low-level laser. It will definitely make a better you. Use it right, it'll make a better them as well. So I am happy to take any questions you guys may have.
Yep, thanks for that, Rob. Again, very insightful. We try to make these webinars as generic as possible. What we feel our duty is to try to arm everybody with the necessary levels of information so that you can make your own decision. If it's for you, if it's not for you, it's completely up to you. But, when you have your own business, you have your own patients that you want to give the best treatments to, do your due diligence, do your educational webinars, look at the research. We've had situations recently. We have a very big advocate of ours who's doing a webinar in a couple of weeks, Rob, with Dr. Jake Cook. And Jake, when he was doing his university study, he'd already had a accelerate laser. He wanted to do a little thesis on low-level laser. So he went online to do some research and came back and said, guys, I thought you said that it was more of, photochemical effect rather than photothermal. This study, this research article hasn't got a very good write-up. When Rob and I looked at it closer, it wasn't actually true non-thermal laser diode. It was actually infrared. So it's so easy to look at articles, think that you're actually getting a true laser, but it's not. So all I would urge everybody is just, again, to do your due diligence, do your research, ask any questions. You know what will be best for your patients. Our strategy specifically isn't just about repairing patients once they get damaged, as Rob's alluded to. It's about trying to enhance them so that it lessens the opportunities of them getting damaged in the first place. And, I'm 50 now. I have less energy. I have all these little niggly injuries and everything that you get. I did a boxing workout last week. I hurt my wrist, so I've been lasering that. I have been challenging my son through the Apple Watch to see who can burn the most calories per day, etc., etc. And as soon as he gets ahead of me, I go ahead of him. And I think I went up and down the 3-story house. I've got up and down the stairs 20 times 2 nights ago. So my legs the next day, I could hardly walk. And again, I've been using the laser just to try to rejuvenate me at a cellular level when I get up early. If I haven't had much sleep, try to, encourage, everything to start working properly. And that's what happens. And, we've done this Beauty is No Longer Skin Deep, which is specific to, as we do get older, we do lose mitochondria. We do suffer from reduction in energy. We do suffer from less ability to actually fight disease, fight infection, fight viruses. So by, treating with a non-thermal laser, a lot of our clients are treating patients to try to give them an immune boost so that their bodies are in a better position to fight viruses and fight infections, as well as, their normal treatments that they carry out. So look, please, anybody, put some questions on. I know it's late, it's 7:30 UK, 8:30 Central Europe. And I think we've got somebody from the Middle East on as well, out in Dubai. So that is 11:30 p.m. If not, we'll actually answer any questions that you have. But by all means, message Julie. Julie will give you Rob's email. She will give you my email. From a purely Aconia perspective, we are a science and research-based company. So, I've always been a big believer that if you deliver the right level of science, the right level of research, the right level of education to go with it, then to an extent, who needs sales reps, who needs somebody to sell it? You will know yourself whether it's right for your practice and right for your patients. So we'll carry on doing this. Rob's got some ideas for his next few webinars. And there may be a partnership with Dr. Rob Sullivan, again, stripping it back even further and looking at what cells are. So we talk a lot about cells, we talk a lot about mitochondria, but going a little bit more depth into what they actually are. But please email us of any ideas that you have or any subjects that you'd like us to cover. Robert is a very progressive orthopedic podiatric surgeon. He doesn't like to put himself in a box and just treat the areas, below the knee or below the hip. He uses his ability to absorb new information to expand on his education. And he's always sending me articles or sending me research that he's come across. And to an extent, the third-party research can be just as good, if not better, than the Aconia ones, because it's it's purely from somebody who doesn't know who we are. We've got some studies going on at the minute on diabetic peripheral neuropathy. We've got neck and shoulder pain. We always look at different lights. We've got the delivery mechanism. As Rob said, it's not about depth of penetration. It's more to do with creating this systemic effective communication, and the laser is just a delivery mechanism. So Rob, I think everybody seems to be a little bit tired and may want to go to bed. There's no questions. Do you have anything else to add?
No, I'm good.
Great. Well, Rob, again, appreciate your time as normal. Everybody else, we will notify you of the next Rob Sullivan lecture. I think, can you remember Rob Jake Cook's lecture? I think it might be something like the 4th of March, or I think it's around about that. Dr. Rob Silverman's doing something with the social media as well for us in mid-March, and hopefully the both of you will be able to do something together late March.
Yeah, Jake is the 4th.
4th of March, brilliant.
Yeah.
Okay, we'll get invites sent out, guys. Thanks very much again for tuning in. Enjoy your evenings, and yeah, we hope to connect with you very soon. Thank you.
Bye.